Imagine a 32-year-old woman who has been leading a completely healthy, normal life for the past 5 months, and suddenly she presents to the OPD with the complaints of worsening headache, persistent nausea, vomiting, and alarming right-sided weakness. What starts as an acute neurological emergency turns into a profound diagnostic journey. When she first arrived, the medical team immediately focused on stabilizing her. Once she was stabilized, they ordered a series of neuroimaging. A non-contrast CT with CT venography followed by an MRI with MR venography of the brain revealed the culprit. The classical signs of cerebral venous thrombosis, a clot blocking the venous drainage of the brain. On neuroimaging, direct evidences of cerebral venous thrombosis includes the empty delta sign. This sign represents the filling defect or thrombus in the dural sinus. CT venography allows direct visualization of the thrombus as filling defects. Similarly, CT venography, MR venography takes the advantage of luminal filling by contrast material rather than relying on the MR flow phenomenon. But a young, otherwise healthy patient developing cerebral venous thrombosis without any obvious risks is suspicious. And then the question rises, why did this happen? Digging deeper into her medical history and lab works, doctors uncovered a rare underlying genetic condition, antithrombin deficiency. In this rare disorder, her kidneys were leaking antithrombin, a vital natural anticoagulant protein, into the urine. Without enough antithrombin circulating in her blood, her coagulation system lost its primary brake, leading to severe clotting abnormalities. Microthrombi developed silently, eventually lodging in the cerebral veins and precipitating her acute presentation. She was treated, managed, and successfully stabilized, but the story doesn't end there. A few months later, despite initial recovery, she developed the exact same neurological complaints. The doctors went back to hunt for a triggering factor. Infection ruled out. Autoimmune conditions ruled out. Trauma or surgery? None. Finally, a meticulous medication history revealed the missing piece of puzzle. She has been using oral contraceptive pills for birth spacing. Here is where pharmacology meets the clinical reality. Oral contraceptive pills introduces exogenous estrogen, which significantly increases the hepatic production of clotting factors while suppressing the natural anticoagulants. In a patient with normal physiology, this is usually well tolerated, but layered on top of an underlying genetic antithrombin deficiency, the OCPs started to act as a powerful catalytic trigger, tipping her already fragile hemostatic balance straight back into acute thrombosis. The immediate medical advice: stop the pills immediately and transition to non-hormonal methods of contraception. This case serves as a powerful reminder that history taking must go beyond the surface. In patients presenting with unprovoked or recurrent thrombotic events, especially females, always screen for inherited thrombophilias and meticulously review the exogenous triggers like hormonal contraceptives. Estrogen-containing therapies can be a ticking clock when combined with underlying hypercoagulable state. If you found this case breakdown helpful, make sure to hit that like button and share it with your fellow medicos, and subscribe for more clinical pearls and case discussions. Stay curious, stay safe, and I'll see you in the next video.